Welcome to this presentation. My name is Dr. Sanjeeva Gupta. I'm a consultant in pain medicine in the UK. My affiliations are mentioned here. I'm currently a consultant in pain medicine at the Bradford Teaching Hospitals. I also practice at Nuffield Hospital and Spine Hospital Leeds and the Yorkshire Clinic in Bingley. I'm an elected board member of the Faculty of Pain Medicine of the Royal College of Anaesthetists. I'm the chairman founder of the North England Pain Medicine Group, director of Leeds Interventional Pain Medicine Cadaver course, and a senior instructor at the Spinal Intervention Society, USA. I instruct on the European courses. And my website is mentioned here, www.drsanjeevagupta.com. Today I'll be discussing about fluoroscopic anatomy for minimally invasive techniques in the management of pain of spinal origin. This is to accompany the chapter that I published in the Atlas of Interventional Pain Management Procedures, a stepwise approach of which I am one of the editors. This has just been published and is available on the market. And here is a picture of the Atlas, what I'm mentioning. To make it easy to sort of understand and to make the presentation a little less longer, what I have done is I have divided the chapters into the presentation into two different parts. In the first part, I will cover fluoroscopic anatomy for minimally invasive techniques in the management of pain originating from the lumbosacral spine. And in the second part, I will cover the fluoroscopic anatomy for minimally invasive techniques in the management of pain originating from the cervical and thoracic spine. There will be some overlap regarding some of the basic principles, but I think doing this, it will decrease the length of the or shorten the presentation, which audience may wish to listen to. So a bigger picture of the Atlas that's been published, Atlas of Interventional Pain Management Procedures, a stepwise approach. And I have contributed to several chapters in addition to being an editor. This was my dream project, and I should thank Dr. Baheti for taking the lead as well in getting it through for all the hard work he has done. These are some of the good practice guidelines published by the British Pain Society and the Faculty of Pain Medicine. I have shared all these three guidelines. Recommendations for good practice in the use of epidural injections for the management of pain of spinal origin in adults, mainly concentrating on epidural type injections. I also shared the recommendations for good practice in the use of medial branch block and radiofrequency techniques for lumbar facet joint pain, and also standards of good practice for spinal interventions, which all have been published by the British Pain Society and the Faculty of Pain Medicine and are available on the website. Some basic principles: understanding the neuroanatomy of different structures that can cause spinal pain is essential before attempting any spinal interventions at all. As you all know, on fluoroscopy, we can only see bony structures and have to construct a 3D image in our mind and consider the different structures that are in relation to the bone, because bone will help us to sort of give a landmark, but the structures around the bone have to be imagined. For that, understanding the neuroanatomy of the spine is very essential. Bony anatomy and the surrounding structures may not be the same in every patient, especially when patients have lumbar spondylosis or excessive osteophytes or spondylolisthesis and other changes in the spine. The structures may not be exactly where they're supposed to be. For example, if there is significant osteophytosis or spondylolysis, the nerve root, the position of the nerve root may not be exactly where it is normally. It can move. Likewise, if there is excessive spondylolisthesis, again, the structures may not, it may be difficult to block the given structure. So there is a lot of planning that needs before you start these procedures. Bones are our friend and our eyes. This is a very important statement, because on fluoroscopy, you can only see bones. And as I said earlier, you have to construct a 3D image and imagine the structures around it. And if at all you are when you start the procedure, it's always important to try to contact the bone before navigating the needle deeper, as this, in my opinion, will increase safety. So, for example, if you're doing a subpedicular transforaminal epidural, instead of just going just below the pedicle straight away, it may be reasonable to contact the very lower end of the pedicle and then directing the needle just below the pedicle, so that you're not too deep and don't injure the nerves. If you're a beginner, always start with simple lumbar spine interventions and then consider cervical or thoracic interventions. I always say in my presentations that it's better to do at least a minimum of 100 lumbar procedures before you even think of doing cervical procedures. If you're having difficulty in identifying the target points, look at the target points one level above and below, and this can help identify the target point in question. In some patients, changing the position, say for example, if I'm doing a cervical procedure or lumbar procedure, for example, just changing the position of the patient or changing the view of the fluoroscopy, taking a break for a few seconds even, and reflecting on what is being done and looking at one level above, one level below, and then trying to judge where the target point could be. Normally, if you do these maneuvers and think about this, you will be able to identify the target points. And the target points can be quite difficult in patients who have osteoporosis or excessive spondylolysis. So just use these basic principles. Most important here is bone is our friend and our eyes. Contact the bone and then navigate deeper. This will make the procedure much simpler. Some more basic principles: use standardized technology to identify the structures for procedures being done. Get the levels correct. It's very important. Count the level from T12 downwards. Be aware of transitional vertebra at L5-S1 level. When performing transforaminal epidural steroid injections, which is one of the commonest procedures we do and which has the most evidence in my opinion, compare the sagittal view of the MRI scan with the lateral fluoroscopic view to confirm that the procedure is being performed at the correct level. If you do an interlaminar epidural, the drug will spread and generally we inject a larger volume. So it is more forgiving in my opinion, but transforaminal epidural is less forgiving because we don't inject huge volume, one. And second thing is that the drug doesn't spread as much as we think compared to the interlaminar epidural. So comparing the sagittal T2 weighted image of the MRI scan and identifying the pathology and comparing that with the lateral fluoroscopic image can confirm that the procedure is being done at the correct level. I will show an example in the next slide, but before that, just to touch upon the cervical spine also, when you try to count the cervical spine levels, count the level from C2 down, because the C2 has the largest spinous process, or it can be from C7 upwards. The C7 transverse process slants down, whereas the T1 slants up. That's how we recognize the C7 transverse process. So you can count from below upwards. Normally in my practice, I use C2 and down because the C2 has got the biggest a spinous process. Now, I was talking to you about the fact that when performing spinal transforaminal epidural steroid injections, compare the sagittal MRI scan image with the lateral fluoroscopic image. This is an example here. You can see here there is a bulge at the L4-5 level, and the L5 nerve root is getting compressed in the L4-5 recess, L5 nerve getting compressed, and at the L5-S1 level, the S1 nerve root is getting compressed. So you can see here I'm trying to do a S1 root block and a L5-S1 transforaminal epidural, and here I can see that that's the S1. You can see that, and that is the S1. So my level is correct, and that is the L5 vertebral body, and that is the L5 vertebral body. So I'm doing a subpedicular technique here for L5-S1 transforaminal. And in this case, the drug is going to go like this. That is, when we do a subpedicular technique, you'll see that the drug normally hugs the pedicle, goes into the epidural space and towards the pathological disc. Same in the similar way, when injected at the S1 level, the drug is likely to go along the epidural space at the site of the pathology, that is the L5-S1 disc. So learning to read the MRI scan can be very useful, and in my opinion, it's not difficult at all. Just you need to put an effort, talk to your radiology colleagues, and they will explain you. And once you start looking at this, it becomes more interesting. And when you show these pictures to your patients, they do get a lot of confidence in you, and that improves the outcome as well, in my opinion. Some more basic principles. Patient position is extremely important. Prone position can be used for all procedures under at the lumbosacral level as well as thoracic level. Cervical epidural can be done in prone position. Lower cervical medial branch block, I prefer to do in prone position. Upper cervical medial branch block, I prefer lateral position. Supine position, cervical medial branch block and RF can be done. Cervical nerve root blocks, if you're doing them, and cervical disc procedures, if you're doing them, can be done in supine position. Lateral position, this is my default position for cervical medial branch block and radiofrequency denervation. Rarely have used sitting position, but one caution, if you're using a sitting position, always make sure that the patient is either on an operating table or on a trolley, never on a stool, sitting on a stool. Reason being, if a patient has a vasovagal, which can easily occur in a sitting position, it will be difficult to lift the patient and put them on a trolley. So be aware that sitting position is not ideal at all. And if at all you're doing, it has to be on a trolley or an operating table. And some colleagues, if at all they contemplate on doing this procedure in sitting position, they routinely give some glycopyrrolate to prevent vasovagal. Cervical median branch block and RF can be done, and cervical epidural can be done. I have not used sitting position for the last maybe 15 years or more. I can easily do procedures in prone or lateral position. A block needle. When I started off as a pain specialist about over 23 years ago, I used to use a straight sort of a needle as shown here, block needle. But 3 or 4 years down the line, I learned about the bent needle technique. And since I've started using the bent tip needle technique, I have very difficulty in doing the procedure using a straight needle because it's so easy to navigate. So using a curved tip needle, or you can bend the curve, the distal few millimeters of the tip of the needle manually. I always bend it away from the hub or in the direction of the bevel. This can assist in navigating the needle to the target point, and it prevents us from going in and out. So say, for example, if we are contacting the bone here like this, if you're doing a transforaminal epidural, if you're contacting the bone, just turn the needle like this, the hub goes and then the needle goes, and then you can turn and go back. Just hug the bone using the curvature. So if you're like this, just turn like this, go down and turn back again, just hug the pedicle, and you'll be in the intervertebral foramen space very easily. This is a diagrammatic representation. This image is borrowed from the Spinal Interventions in Pain Management, published by the Oxford University Press, and I am one of the editors of this book. This book was published to accompany the cadaver course that we conduct at Leeds. We've been doing that for many years now. What this diagram shows is that if a clockwise rotation of the needle takes the needle in this direction, if you just turn the needle by 180 degrees, it goes in a completely opposite direction. So it's not must that you should change by 180 degrees. You can vary this. You can change by 10 degrees or 15 degrees or 30 degrees or 80 degrees or 90 degrees or even more. So it depends upon where you want the needle to go. So if you turn the tip of the needle in this direction, it will keep going like this. So if you hit a structure, say for example a pedicle, you don't want to go this anymore, you want to go below the pedicle, turn the needle direction this way, and then again this way, and you can reach the target wherever you want to go. So it becomes very easy to navigate the needle using a curved tip needle. Fluoroscopy, radiation safety standards should be followed. Agree the terminology to be used when operating fluoroscopic C-arm with the radiographer to decrease unnecessary exposure of X-rays. Now, I usually agree with the radiographer that the top end of the fluoroscopic machine or the C-arm is the reference point. So in relation to the top end, the AP view, the beam comes from below when the patient is in prone position. So you get the AP view. Now moving the top end towards the head, like if the patient is lying like this, towards the head, if the patient towards the head is called cephalic tilt, and towards top end, if moving the top end toward the foot is called caudal tilt, and moving the C-arm to the right is right oblique rotation, and then left oblique rotation. And the lateral view is, of course, this way, yeah, when the C-arm is surrounding the patient there. Now, in the lateral view, sometimes when the patient is here, say for example, you're taking a lateral view. In the lateral view, sometimes you cannot see the structures properly. What I mean to say by that is the intervertebral foramina or the disc space may not be seen appropriately, especially when patients have spondylolisthesis or excessive spondylolysis, and more so in thoracic area as well. In such cases, if the C-arm is moved on either side, we call it wig-wag, that can help square the disc. So if the C-arm is like this, in the lateral position, you're moving the C-arm in sideward direction. Which direction is difficult to determine. You need to go on one side first under continuous fluoroscopy and the other side later on and see which one squares the discs and makes the intervertebral disc visible. So using appropriate terminology, using the top end of the as the reference point and telling the radiographer which side is cephalic, caudal tilt, right or left oblique rotation, this will decrease the radiation exposure to the patient and yourself as well. Good fluoroscopic table with minimal metal objects should be used. Proper positioning is also extremely important. I normally place a pillow under the pelvis and the abdomen, as you can see here. I normally place a pillow, or you can place sheets also. This will sort of eliminate the lumbar lordosis and make the procedure easier as well, in my opinion, to navigate the needle as well. So in that AP view, AP, because the beam is coming from here and going here then to be captured. In the AP view, the most important thing is, that's an AP view picture. Identify the pedicles on either side and the spinous process. You can see the spinous process. So in a true AP view, the spinous process should be in the center of the two pedicles. Fluoroscopy, again, basic principles. The target point should be in the center of the screen. Look one level above and below. So the target point should be in the center of the screen, and one level above and one level below should be visible. The target should be somewhere here or here. That makes it less safer, in my opinion. And use the 3D principle in prone position. The AP or oblique view guides the direction of the needle. So this is an oblique view. This will guide the direction of the needle, not the depth. Yeah. If you want to know the depth, a lateral view guides the depth of the needle. Here you can see the depth of the needle. Just this needle is in the intervertebral foramina. So say, for example, if the needle was somewhere here, needle tip was somewhere here, I wouldn't advance the needle any further, but I'll go back to the oblique view and then advance the needle, making sure that it's not going too medially or too laterally, and then go back to the lateral view to check that the depth is fine. So the 3D principle is direction, depth, back to direction, back depth. So that's how you are likely to make the patient or the procedure much safer. Some more basic principles. Knowing the depth of the different spinal structures in relation to the skin entry point is essential. You look at the image here, you can see that is the L5 vertebral body, and that is the sacral plate there. Lots of osteophytes here, osteophytes from the lower end of the L5 vertebral body, osteophyte from the sacral plate here. You can see the sacral upper end of the S1, yeah, disc osteophytes. So everything is very, very fuzzy here. So you will think, well, where am I going to go here? Am I going to hit any of these before entering into the intervertebral space, intervertebral foramina? So now if you look at this here, I've labeled them. This is the L5 pedicle. Yeah, you can see L5 pedicle. Yeah, these are osteophytes, as I said already. And this is the superior articular process of S1. You can see here, the superior articular S1. And this is the L5 S1 facet joint. And you can see the needle tip here going. So this needle, as you can imagine, has hit the L5 pedicle. And then I've curved the needle. So I've changed the direction of the needle. I'm going below the pedicle there. Yeah. Again, I can turn and be as close to the pedicle as possible. So the reason I was confident is that I know the anatomy, in the sense that the disc osteophytes that are present here at the L5S1 level are much more anterior to my target area. So I can hit the bone, the pedicle here, and then go into the vertebral foramina, and then only I'm going to encounter these osteophytes. So if you know the depth of each structures, which are visible on the X-ray, you can easily sort of know what's going to come in your way and plan your procedure. Likewise, I will discuss later how the ilia crest can come in your way when performing procedures. Some basic principles about lumbar fluoroscopy when performing procedures at the lumbar level. Always first obtain a true AP view. As I said earlier, a true AP view is the spinous process being in the center of the two pedicles. Once a AP view is obtained, then square the vertebral end plates closest to the target point by either a cephalic tilt or a caudal tilt. Normally, at the lower lumbar level, you will need a cephalic tilt. At the upper lumbar and lower thoracic, you'll need a caudal tilt to square the vertebral end plate closest to the target point. And at the thoracic and cervical level, you have to go either way and check which direction, whether cephalic or a caudal tilt squares the vertebral end plate. Once the true AP view is obtained and the vertebral end plates have been squared off by either a cephalic or a caudal tilt, then go right or left oblique to get a Scotty image. Obtaining these images, you can do almost all the procedures at the lumbar spine level. So true AP view, then square the vertebral end plates closer to the target, and then go either right or left oblique rotation. Here, I've gone right oblique rotation, and you can see a Scotty view has appeared. That is the pedicle here, yeah, and that is the snout of the Scotty dog. That is transverse process. The ears form the superior articular process. The forelimb is the inferior articular process. You can see here that is the lamina, and the tail is formed by the opposite pedicle and probably the other structures around, and that is the hind limb there. Yeah, so you can see a very good Scotty picture here. Yeah, and if you get this picture, you can do almost all procedures of the lumbar spine. I'm going to elaborate on that in a short while. One more important thing what you have to notice here is, you see that is the vertebral end plate of the top end of the L5, yeah, and that is sometimes what happens is it can be mistaken to be the transverse process. You can see here the superior articular process and the junction of the superior articular process with the transverse process here, and sometimes it's very easy to mistake the top end of the vertebral end plate to be the junction of the superior articular process and the transverse process. So just see through the images and try to identify the structures. Here, I'm just showing what a cephalic tilt looks like. This is the CR view from the side here. The L4, 5 and the L5 vertebral end plates are squared off here. So as I said, true AP view with the pedicles here and the spinous process in the center, then a cephalic tilt to square off the vertebral end plates. Unfortunately, there is significant degenerative changes at the of the disc here. This disc space is so narrow here compared to the one above. So once you get a true AP view and you square the vertebral end plates, then identify the structures. So at every point, you need to identify the structures and then proceed to further sort of what you want to do. So here, if you look at this, that's the vertebral end plate. Yeah, that is a transverse process of L5. That is a spinous process. You can see that. And this is the interlaminar space. You can see that. This is the inferior articular process, the superior articular process of L4, and the junction of the superior articular process and the inferior articular process is known as pars intraarticularis. You will have read sometimes the MRI report, especially at L5, S1, L5 level, there is pars intraarticularis defect here, they will say. Yeah, what it means is if there is a break between the continuity of the superior articular process and the inferior articular process, that leads to fracture at the pars intraarticularis area, and that leads to spondylolisthesis. The vertebral bodies will move, and that will make any facet-related procedures quite difficult. Any procedure for that matter, even root block or transforaminal epidural can be difficult because the anatomy has changed. So knowing what's happened helps you to plan the procedure. These are the vertebral end plates. This is oblong here, it's not squared off. Of course, we are looking at the lower level here. That's also vertebral end plate, yeah. And these are the pedicles. You can see the pedicles, yeah. And that's the lamina. So vertebral body, transverse process, inferior articular process, superior articular process, pars intraarticularis, vertebral end plates, pedicles. You can see pedicles, lamina, spinous process, and in interlaminar space for interlaminar epidural. Now here I'm just showing a picture where there's a caudal tilt. As I said, the top end of the fluoroscopic C-arm is considered as the reference point. And again, in this picture, we're looking at left oblique rotation. Yeah, that's from the top end of the head end. And in that, you get this picture. Yeah. So at every point, once you obtain this picture, identify the structures again. That is a L5 vertebral body here. That is a pedicle, superiorarticular process of L5. Here you can see the superiorarticular process of S1. The iliac crest is here. So iliac crest is posterior. So you'll not be able to do any procedure here because the iliac crest will come in the way. Yeah. Similarly, intervertebral discs. Yeah. And the facet joints here, facet joints, superiorarticular process. So identifying the structures in each projection will make the procedure much safer. So as I said earlier, that is a Scotty view, and this is an artifact, and that's also an artifact. Just be aware of that. That's the lamina, and you can see a beautiful Scotty dog again, a stout, short Scotty dog, which you can see. So inferior articular process, pedicle, superior articular process, disc, vertebral end plates, yeah, and the iliac crest is here. So identify the bony structures in every projection to make the procedure safe. Again here, identify, I'm asking a question here, identify the junction of the L4 superior articular process and the transverse process. So that is L4, you can see the superior articular process of L4 and the transverse process. So it's a beautiful curve here. It's ideal for medial branch block and radiofrequency denervation. Same thing here as well, but the vertebral end plate has not been squared here. Here the vertebral end plate is squared, appears like a single line here, but here it appears oblong. So any procedure you do at this level might not be appropriate, but at this level, you can easily do a block here. For medial branch block, your needle is here. For subpedicular transforaminal epidural injection, the needle is going to be in this area. And here you can see I'm trying to do medial branch block at the L5 level. So at that level, we block the L4 medial branch at L5 level. So you need to know the neuroanatomy of the spine very well before you start these procedures. Identifying two key structures at the lumbar level should help you to do almost all the procedures at the lumbar level. So say, for example, superior articular process. If you identify the superior articular process, then you know the facet joint injection can be done if you're doing them still. Medial branch block can be done, and discogram can be done by entering the sort of a disc just at the top end of, just in front and the middle of the disc. Say, for example, here it may be better. At that point, if you just in front of the superior articular process in the center of the disc, if you enter, go along, then hit the superior articular process and then change the direction of the needle and go below, go past the superior articular process into the disc. Radiofrequency denervation can also be done in this sort of a image, using this image. Pedicles are good for nerve root block. You use a subpedicular technique there, yeah, or a vertebroplasty, wherein you go through the pedicle into the vertebral body to inject the bone cement in a vertebroplasty. So two structures, superior articular process and pedicle, if you identify them, you can do almost all the procedures at the lumbar spine level. Here I'm showing a C-arm in right oblique view. You can see that the C-arm is in the right oblique view and a corresponding image here. So as I said earlier, obtain a true AP view with the pedicles on either side and the spinous process in the center. Then go cephalic or caudal tilt and square the vertebral end plate closest to the target. People ask, oh, which vertebral plate should I square? Because sometimes in a single vertebra, you'll not be able to square both the top and the bottom end vertebral end plate. So we say that square the vertebral end plate closest to the target point by cephalic or caudal tilt, and then go right oblique to obtain the Scotty view, and then identify the structures again, as I've already told, before embarking on doing any procedures. In this image, I'm showing that the tip of the needle is at the junction of the superior articular process of S1 and the ala of the sacrum. So I'm attempting to block the L5 dorsal rama here. And what you have to remember is when you're doing this procedure, you may not get an optimal view all the time because the iliac crest may come in your way. So putting a pillow under the lower abdomen and pelvis can help to sort of get a proper image, in my opinion. So you can see the block needle is here. There is a superior articular process of S1, iliac crest, and the ala of the sacrum there. Yeah, here. In this picture, I'm showing a lateral view. The vertebral end plates are squared off with the disc space and intervertebral foramina visible. The insert shows C-arm from the head end. So from here, I can see the lateral view here. The patient is lying on a pillow, as I said earlier, to decrease the lumbar lordosis, and that's from the top end. In the lateral view again, you have to identify the structures again before you start doing anything at all. So that is the disc space there. You can see the disc space here. Yeah, intervertebral disc space, L34, L45, and the L5S1, and that's the intervertebral foramina, and you can see the needle there. Yeah. So in the lateral view, sometimes the intervertebral foramina and the discs may not be crisp. So moving the C-arm in the lateral view in either direction, we call it wig-wag, yeah? Moving it either in this direction or in this direction. So basically, the whole C-arm goes like this or like this. Wig-wag, what we call commonly, can help to square the vertebral end plates and identify the disc space more crisply, as well as when you do that, the intervertebral foramina becomes much more visible. As I said earlier, if patients have spondylolisthesis or excessive spondylosis with osteophytes, it can be difficult to identify the structures. So in such cases, wig-wag in lateral view can help to identify, more so in thoracic spine level, where the ribs and also lung air shadow, using a wig-wag sort of a maneuver when doing lateral fluoroscopy to make sure the depth of the needle is appropriate. The wig-wag can help us visualize the intervertebral foramina more easily. Now, we will try to go through some of the procedures, and in that process, try to understand the fluoroscopic anatomy. In this presentation, I will be covering the lumbar spine, medial branch block, transforaminal, S1 root block, then sacroiliac joint injection, and disc access. In the second presentation, I'll be covering cervical and thoracic procedures. Now, targets, this image shows targets for L3 medial branch block at the eye of the Scotty dog at L4 level, and L4 medial branch block at L5 level. So identify the structures again. Vertebral, that's the vertebral body. Vertebral end plate has been squared here as well. Yeah, and that is a superior articular process, facet joint. The transverse process can be barely seen here. So the target point is here. So understanding the neuroanatomy is important because you're blocking the L3 medial branch at the L4 level, and you're blocking the L4 medial branch at the L5 level. So that blocks the L nerve supply to the L4-5 joint. But if you include the medial branch, the L2 medial branch at L3 level, you'll be blocking the L3-4 and L4-5 facet joints. On the other hand, if you include the dorsal ram of L5, you will be blocking the L4-5 and the L5. So basically, the facet joints are supplied by two nerves, basically. So when you block the medial branches at L3 and L4, the L4-5 facet joint is blocked, and if you block the dorsal ram at L5, then two facet joints can block. Basically, understand the neuroanatomy, and that will be very helpful. The most common facet joint involved is at the L5S1 level, followed by L4-5. Think about these more common ones first. This is a picture of, in the past, about 15 years ago, we used to do facet joint injections with steroid. This is a signature appearance, what they call for facet joint. But the reason I'm showing this is that I had one case wherein they did a facet joint injection, and probably the needle went through the facet joint and injured the nerve, and the patient had significant nerve root problems. And in that patient, I think I did a root block, and that helped the patient. So be very careful when doing facet joint injections. The needle can go through the joint and injure the nerve. So if at all you are worried, then I don't normally do a lateral view for facet procedures, but if you're worried, take a lateral view. The needle tip should be posterior to the intervertebral foramina. Challenges encountered. identify the junction of the superior articular process and the transverse process here. What I'm trying to show here is at the L4 level, there are significant osteophytes, as I have marked here, significant osteophytes, yeah, both sides actually. Now, as I said earlier, that is the superior articular process of L4, and that's the vertebral end plate with osteophytes, yeah. Sometimes the junction, what is appearing here, of the superior articular process and the vertebral end plate can be mistaken to be the junction of the transverse process with the superior articular process. And if you end up doing an injection at this point just below, you may go past the superior articular process in front of the superior articular process and hit the nerve and damage the nerve. So be very careful in looking for the anatomy. That's the reason. Identify the vertebral body, yeah, properly in every projection. Identify the superior articular process and where the pedicle is, yeah, and then do the procedure. The simplest of the procedures can become a bit complicated sometimes, and we can end up with a serious nerve injury. Left oblique view for subpedicular transforaminal epidural injection. As I said earlier, get a true AP view with the spinous process in the center of the two pedicles, then cephalic or caudal tilt, in this case cephalic tilt, to square the vertebral end plate closest to the target. Now you can see here, the vertebral end plate at the top end is quite oblong, that's not squared. But at the lower end, it is still not squared, but it is a compromise. Sometimes you don't get the absolute clear picture. Sometimes you have to compromise. But the closest, the vertebral end plate closest to the target point has been squared as much as we can. Maybe I could have gone a little more cephalic tilt to square this a bit more. But the point I'm making is that go in a systematic way, true AP view, cephalic tilt, and then right or left oblique, in this case left oblique. Then identify the structures. Again, I know I'm stressing this again and again, but it's so important. Vertebral body, pedicle, superior articular process, inferior articular process, and that's the block needle. You can see the vertebral end plates and the L5 pedicle, L4 pedicle. Again, as I said, 3D principle is also important. In this view, we can get the direction of the needle. If you go lateral, you can gauge the depth. If you're not too deep, come back to the oblique image and go deeper, maintaining the right direction. If you go too medially here, if you look at this, it should be lateral to the 6 o'clock position. That is 12 o'clock, 3 o'clock, 6 o'clock. It should be lateral to the 6 o'clock position. If it's too medial, you're more likely to enter the dural sleeve, and that will become intrathecal injection. So just be mindful of that as well. So once the direction of the needle is assessed, now look at the depth of the needle. And again, identify the structures. That is the vertebral body. Yeah. That is the pedicle there. Yeah. Superior articular process, inferior articular process, L4-5 foramen, vertebral end plate, L5 vertebral body, and vertebral end plate. So identify the structures in each projection. It makes it safer, and you can see the needle is exactly, tip is exactly in the intervertebral foramina, just below the pedicle. That's the reason it's called subpedicular technique. AP view, needle in position for left L5-S1 transforaminal epidural injections. And here you can see the tip of the needle is here. And on injecting the contrast, the normal flow goes superior along the pedicle and into the epidural space and along the L5 nerve root. Yeah, you can see the L5 nerve root, pedicle, and the epidural space here. One thing I have to mention, I'm going to mention it again later on as well. Whenever you do a transforaminal epidural, if you are using a fluoroscopy image to rule out vascular spread, always inject contrast under continuous fluoroscopy through an extension tubing attached to the tip of the hub of the needle. So inject the contrast under continuous fluoroscopy. So if you see the runoff in this direction or any direction, that's going to be a vascular spread. A static image will easily miss that. So always inject contrast through an extension tubing under continuous fluoroscopy to rule out vascular spread or abnormal spread. Ideally, digital subtraction is better. Again, at L5-S1, the procedure can be technically difficult, as you all know. Please, I've asked a question here. Please identify the structures of the lumbar spine relevant to the L5-S1 transforaminal epidural injection here. You can look at the pedicle here, superior articular process of S1, L4-5 facet joint, L5-S1 facet joint, superior articular process of S1. These are osteophytes. I think I've already dealt with this also to some extent. and we know that this is deeper than our target area from the skin entry point, and you can see the needle there in the subpedicular area. And that's a lateral view where you can see that the tip of the needle is in the intervertebral foramen. So again, as I said, direction, depth, direction back again before you navigate the needle any more deeper. If fluoroscopy is used for transforaminal epidural injection, as I said earlier, the contrast should be injected in AP view, not lateral view, under continuous imaging to rule out vascular spread. This was one of my cases, actually. So contrast under continuous fluoroscopy, you can see vascular spread. When I'm injecting contrast, this is extension tubing through which I'm injecting the contrast. That's the needle. You can see an epidural spread also, but more importantly, you can see a vascular spread here. Yeah. But on the other hand, if it's a static image, if I inject and then take an image, that's how it appears, and the vascular spread will be completely lost. So what do you do? How do you manage a patient if you get a vascular spread? So in this case, I withdrew the spinal needle, and I did targeted interlaminar epidural at L5S1 level, directing to the left because the patient's pain was mainly in the L5 distribution, and I was successful. However, there is contrast medium already in the epidural space, so one has to be very careful. The other alternatives are, some of my colleagues, or I've also done some time, that withdraw the needle or go deeper, whatever is appropriate in a given case, and inject the contrast again. If there's no vascular spread, then I would inject a non-particulate steroid with local anesthetics, the non-particulate steroid being dexamethasone. In fact, as a default, non-particulate may be safer than particulate steroid for transforaminals, but that again can be argued at the lumbar level. Cervical level, certainly that should be the case. A non-particulate steroid should be used. The other option, if the lower S1 is involved and the L5 is involved, a caudal epidural can also be considered in such encounters. Contrast injection in AP view under continuous fluoroscopy. What can you see? As I've already said, that you can see a vascular spread. Would you inject steroids? I've already said that non-particulate steroid may be injected after withdrawing the needle or going a bit more deeper and confirming that the vascular spread has disappeared. But I would certainly not inject a particulate steroid once I've observed a vascular spread. Or look at alternative ways. Interlaminar epidural, a caudal epidural could be considered. Here I'm showing a lateral view showing the needle tip at the L5S1 intervertebral foramina. You can see that that's where the needle is. Comparing the lateral fluoroscopic view with the sagittal T2 image, T2 MRI scan image confirms that the procedure is being done at the correct level, but beware of the transitional vertebra. Now here, the most important pathology is here. This patient had L5 radicular pain because of compression of L5 nerve root in the L4-5 recess. Although this disc is bulging, the S1 nerve root, you can see that here, was not involved, and the patient did not have any symptoms in the S1 area. So the aim was to do a L5S1 transforaminal epidural in the hope that the drug will go above, and that's what we are trying to do here. The needle tip in the lateral view is here, and the pathology is here. So when a contrast is injected, it will go along the pelvis. Of course, it should be in the AP view under continuous fluoroscopy. It's going to go towards the target pathology. The aim of showing this slide is mainly to make sure that we get the correct level. And this slide, as I said earlier, I've already shown this. That is the L5 pedicle, and that's the tip of the needle here. The pathology at L4-5 compressing the L5 nerve root, pathology at L5-S1 compressing the S1 transiting nerve here. Yeah. So doing L5-S1 transforaminal and S1 root block will cover the pathology and help the patient. Now moving on to the sacrum, S1 root block can be challenging. As I said, identify the L5 pedicle, L4-5 disc here, L5 vertebral body. That is the sacral plate, as you can see here. And when you're doing a sacral S1 root block, it's important to get a true AP view first with the spinous process in the middle of the two pedicles. Yeah, middle of the two pedicles, S1 pedicle here, and another one here. That's the spinous process of S1. You can take L5 as well as a landmark or a guide as well if you can't see the S1 spinous process. Once you get a true AP view, then go cephalic tilt to square the L5-S1 disc as much as you can. Yeah. Initially, when I started, I didn't sort of do a cephalic tilt to square the vertebral end plate as much as I can. And it was quite difficult to see the S1 foramina. But once I started giving a bit of a cephalic tilt to square the vertebral end plate, the S1 foramina becomes much easier. And if you're having still difficulty, look at the L5 pedicle, identify the S1 pedicle, and look just below that, you'll start seeing the foramina. And sometimes a slight sort of a right or left oblique rotation, tiny bit, not much actually, maybe 2, 3, 4 degrees, depends upon individual patients, may also make it more visible. In this case, very luckily, I was able to see the S1 for S2 foramina, S3 foramina you can see, and the S4 foramina. Normally, the S3 foramina corresponds to the lower end of the sacroiliac joint. If you're doing a sacral nerve stimulator, that's how you try to identify the S3 foramina. Yeah. So in this case, I'm trying to attempt S1 root block, and you can see the needle is just entering the foramina. Normally, if you're doing S1 root block, it's preferable to have the needle in the medial half of the foramina. That will decrease the chance of vascular spread. There is a chapter in that particular book I told about, the Atlas of Interventional Pain Management Procedures, a stepwise guide. We have discussed about a stepwise approach to S1 root block in that book. You may wish to look at that as well. In the lateral view, L5 vertebral body, L5 pedicle, L5 S1 disc, yeah, and you can see S1 vertebra, S12 disc, and the needle tip is at the in the epidural space at the S1 level. So you can see that is the AP view direction. Again, as I said, direction, depth, and direction, direction, depth. If it is not deep enough, then go back to the AP true AP view and the cephalic tilt, and navigate the needle further, and then go back and check if it is deep enough. And normally, when you inject the contrast is more likely to go this way. But if it just goes this way and doesn't go to the site of a pathology, you may have to go deeper, or you may have to withdraw the needle and re-inject the contrast. Again, as I said, there is a separate chapter in this book about difficulties encountered while doing S1 root block and how to overcome those difficulties. S1 root block, patient in prone position with the pillow under the lower abdomen and pelvis. AP view with cephalic tilt in an attempt to square off the L5 S1 disc helps to identify the S1 foramina. If having difficulty in identifying the S1 foramina, consider identifying ipsilateral L5 pedicle, and then try to identify the S1 pedicle and S1 foramina, which will be just below the S1 pedicle when trying to do a subpedicular technique. I know this figure is a bit hazy. That is the L5 spinous process, L5 pedicle, S1 pedicle, and the needle is going into this S1 foramina, and there is L5 S1 disc. It's important to see such images as well, because every time you'll not see perfect image, patients will have osteoporosis, patients will have excessive spondylolysis. So it's nice to see image which is not perfect as well. Now, targeted L5 S1 interlaminar epidural. So if you're having difficulty, or if you think that, well, you are unable to do transforaminal epidural, like I showed one case, there was a vascular spread. In such cases, you can revert to a different sort of a relevant procedure. So in this case, targeted L5 S1 left-sided targeted interlaminar epidural has been done. So be careful. When you consent a patient, you need to keep all these things in mind, alternative techniques, and discuss with the patient that in case I have difficulty, then I'll have to alter the sort of a technique to get the same effect or get the drug in the same place. I will have to just alter the technique just so that the patients are aware that this is a possibility. Here, left oblique view showing the needle in place at the left S1 foramina and L5 S1 foramina. Here, of course, this S1 needle was placed in a AP view, not in oblique view. And once that was done, I'm trying to attempt to place a needle at the L5 S1 level. But in this case, I'm using a slightly different technique. I'm not using the subpedicular technique. That's the L5 pedicle. Yeah. And I'm using a infraneural retrodiscal technique. Infraneural because it will be below. If the L5 nerve root is going in this direction, it is infraneural. And in the lateral view, using the infraneural technique, it will be just behind the disc, actually. So it's called as infraneural or retrodiscal technique. In this technique, what we do is instead of going subpedicular, we go, that's the superior articular process of S1. So you go just lateral to the lower border of the superior articular process of S1, lower or maybe slightly higher if necessary. Touch the superior articular process, then turn the needle, curve needle, go past, and then again turn towards the superior articular process so that you're going to go as medial as possible and go past the superior articular process. So doing that, the reason I'm doing this is trying to get the pre and post ganglionic sort of fibers. So injecting the contrast from below, it will go towards the disc. From here, when you do a retrodiscal infraneural technique, the contrast is more likely to spread downwards rather than upwards. In subpedicular, it normally flows like this. In the infraneural retrodiscal technique, it is likely to spread lower as well as above, but that's the reason I'm trying to cover the site of the pathology from the top as well as from the bottom. Moving on to sacroiliac joint. Here you can see the right sacroiliac joint. This is an AP view. Normally, the medial joint lines are the posterior joint lines, which you can access. You can't access the anterior joint lines because that's in the pelvis. So the medial joint lines will be the posterior joint lines. And whenever patients come with sacroiliac joint pain, how do we identify it? Sacroiliac joint pain is commonly missed, actually. Sacroiliac joint pain commonly occurs in women. 95 to 98% of my patients who have sacroiliac joint are women, and they're multiparous. And when on examination, you'll find that the pain, although they may have lumbar pain and sort of a pain in the sacral area, their pain will be more below L5-S1 level. And they will be quite tender over the sacroiliac joint and the posterior superior iliac spine. And I do a Faber test as well to see if that provokes their pain. So female patient, multiparous, can be bilateral, can be unilateral, significant pain below L5 level, and tenderness over the sacroiliac joint and the posterior superior iliac spine. It makes me think that this patient is likely to be having sacroiliac joint pain. Now, for the facet joint pain, when you get a true AP view and square the vertebral disc into vertebral disc and go oblique, ipsilateral oblique. But for sacroiliac joint, normally it's AP or contralateral oblique. That's what I'm trying to say here. So it's contralateral oblique compared to for medial branch block, it is ipsilateral. So it may be just a few degrees of contralateral oblique. Here, the anterior joint line and the posterior joint line have been sort of aligned. So you can see a clear space there. And normally we enter at the lower half inch of the facet joint, not somewhere higher up. And here you can see I've entered at the lower half inch of the sacroiliac joint and injected a 0.5 ml of contrast, and you can see the spread here. And if you see a thin line like this, I think it's very encouraging, and you know definitely that the needle is in the right place. You can see a beautiful image. And if the pain is coming from the sacroiliac joint, the patient will complain of concordant pain or severe pain on injecting even a tiny amount of contrast, because you're pressurizing the joint where the pain is originating from. And if you do an MRI scan of patients who have sacroiliac joint pain, in a good number of patients, the pathology will be normal. There will not be any pathology at all, but still they will have sacroiliac joint pain. And there are two ways of identifying sacroiliac joint pain, either by blocking the sacroiliac joint nerves, the L5 dorsal rami, and the S1 lateral branch, S2 lateral branch, and S3 lateral branch. Yeah, that's one way of identifying if the source of the pain is being carried by the nerves that are blocked. In my clinical practice, I prefer to inject about 20 to 40 milligrams of triamcinolone along with local anesthetic into the sacroiliac joint. And the local anesthetic works fairly immediately. And I ask patients to keep a note of their pain before the procedure, do all the maneuvers that makes it worse, and imagine their pain to be 10 out of 10 or 100% before the procedure. And then after injecting local anesthetic and steroid, I go and see them again, ask them to do all the maneuvers or movements that used to cause pain, and tell me how much the pain is better. Is it no better, or 50% better, or 80% better, or 100% better compared to what it was before the injection on doing such maneuvers? That will tell me if the pain is originating from the sacroiliac joint at all. So adding local anesthetic helps us to diagnose if the sacroiliac joint pain is the source of their pain. And adding a small amount of steroid, in my opinion, I've seen greater than 50% of my patients do respond with good pain relief for weeks to months after a single injection of a small dose of steroid. So it's purely a diagnostic procedure, in my opinion. That's what I tell the patients. But adding a small amount of steroid can make it therapeutic. Will it make it therapeutic even if you don't add steroid? I've had 2 cases where there was some reason I could not add steroid, and one of them did get few months pain relief, I should say that. So it is debatable adding steroid is a must or not, but in my practice, I do feel that it might help, and the amount of steroid we use is very minimal, 20 milligrams in a joint. And if it helps them for a few weeks to few months, then it's well worth it. The way I look at it is, now, what are the side effects of pain? Yeah, disability, suffering, immobility. All these things can cause osteoporosis as well because of immobility. As compared to that, what is the side effect of 20 milligrams of triamcinolone? So on balance, I feel that it's quite reasonable if the patients can get good pain relief and improve quality of life with a small dose of steroid with a simple intervention like this. This is a double needle technique which I described and published in Pain Physician in 2011. Now, sacroiliac joint, although it's a fairly big joint, sometimes it can be very difficult to enter. I know that there are papers saying that, well, if you inject 5 or 10 ml of local anesthetic around the joint, that is good enough, or that's equal to injecting the joint. I don't think I believe in that. Being very targeted and injecting into the joint certainly has a better outcome, in my opinion. So I strive my best to put the joint, the medication in the right place as much as I can. In this view, you can see the tip of the needle appears that it is in the sacroiliac joint, lower end. But on continuous fluoroscopy, once you get the correct picture and place the needle, do a continuous fluoroscopy on either side and see if the tip still remains in the joint or comes over a bone. Here you can see it's on the bone here. It's not in the joint. So in such situations, I identify another sort of a area where it is translucent. Yeah, before injecting any dye, I identify that and put another needle. So you can see there's one needle here, and that was the first needle, that is the second needle. Now, if I inject contrast through the first needle itself to make sure that it's, to find out if it is in the joint or not, I lose the landmarks, and I cannot really, once I've injected contrast, if it is not in the joint and spread around, it becomes difficult to identify and place the second needle. So even before injecting any contrast, put the second needle, and in this case, I injected contrast through the second needle, and it spread very nicely along the sacroiliac joint. Yeah, of course, using 2 needles, there's 2 skin puncture site, so that will increase the chance of infection, but use a sort of as clean, sterile way of doing this procedure, that will decrease. But getting the right medication in the right place can be very rewarding and useful for the patient in terms of long-term pain relief. L5-S1 intervertebral disc access can be challenging because the iliac crest can come in the way. Yeah, and if you don't have a proper table, this is not a proper table. There's an artifact. There's a table artifact. So get, again, true AP view, cephalic tilt to identify, square off the vertebral disc closest to the target point, and then right oblique view in this case. Make sure the iliac crest is not in the way, and go as oblique as possible. And just in front of the superior articular process of S1 in the middle of the disc, enter, hit the superior articular process if you wish to, curve it laterally, turn the needle by 180 degrees and go past the superior articular process, turn it back again towards the superior articular process, the curvature, and enter the disc and check in the lateral position how deep you are. So you can see here, it's a right oblique view. Identify the structures, vertebral body, that is the pedicle, superior articular process of L4, and using a gun barrel technique, just in front of the superior articular process of L4, in the middle of the disc, we are entering the intervertebral disc. And this is a lateral view. So as I said, direction, depth, direction. Yeah, that is the lateral view. Again, the disc spaces here. So normally at the lumbar level, if a discogram is planned, a 3-level discogram is planned to find out if there is any pathological disc there. In this case, when I injected contrast at the L3-4 level, no pain at all. It's confined to the intervertebral disc. And when I injected contrast at the L4-5 level, you can see the contrast is leaking into the epidural space. So this patient had an annular tear, and that injecting contrast increased the pressure in the disc, and that produced concordant pain. and this injecting L5-S1 did not reproduce any pain. So you have two controls and one positive. So you can be fairly confident that that's the pathological disc which is causing the pain. Here you can see the dye spread in an AP view at the L5-S1 level. This is a different patient. Here you can see a right oblique view. The tip of the needle is in the pseudo joint between the right L5 transverse process and the ala of the sacrum. So this patient complained of pain in the lower back. So I felt that it could be the L4 and L5-S1 facet joint and the L34, L4 and L5-S1 facet joint. And I felt that it might be reasonable to examine under fluoroscopy. So you have to remember this as well. Clinically, especially if patients are obese, you may palpate and do anything else, but you can't exactly identify the levels. If you want to be very precise, then it's okay to examine the patient under fluoroscopy to make sure that you do the right procedure at the right level. So in this case, when I examined the patient, most of the patient's pain was in this area. And if you look at this, there is a pseudo joint between the transverse process of L5 and the ala of the sacrum. So I didn't do any medial branch block or anything like that in this patient. The patient was fully awake, no sedation at all. So I decided to enter the pseudo joint and inject steroid. Because of the changes, you can see L5-S1 foramina that's formed here, L5 pedicle, L5 transverse process, pseudo joint, and the needle tip is entering here. And on injecting the contrast, you can see the contrast is spreading along here. Maybe there is some spread into the foramina as well. Maybe there's some communication there, difficult to say. That is the L5 superiorticular process, and the iliac crest is not coming in the way. It's just about there. So you can inject. We know that the iliac crest is posterior to the target area. So you can't go any more oblique there. So that is the tip of the needle there with the contrast spread. And this patient has had very good pain relief. These are some books which may accompany the atlas, which has some theoretical aspects of managing spinal pain. And this is a complex cancer pain, which we published recently this year from the Oxford University Press. This is just for your information. So in summary, basic principles are extremely important. Patient position is extremely important, how we position the patient, eliminating lumbar lordosis. Understanding the fluoroscopic anatomy and the structures in relation to the fluoroscopic bony anatomy is extremely important. And understanding neuroanatomy is also very important. Using the 3D principle always, direction for AP and oblique view for direction at the lumbar spine level. If you want to gauge the depth, it has to be lateral view, and back to direction if the depth is not adequate. So direction, depth, and direction principle, especially when you're beginning to do these procedures, if you follow this, it will become much safer. And when you're doing a transforaminal epidural, it is okay to use continuous fluoroscopy in AP view when you inject contrast to rule out vascular spread, but ideally digital subtraction would be better. Bones are our friend and eyes. If you are in any doubt before going any more deeper, contact the bone and then only navigate further. Sequential fluoroscopy is extremely important. As I said, I can't stress this more. True AP view, then cephalic or caudal tilt, and then right or left oblique. At each level, identify each structure and make sure that you are able to see. If you're having difficulty, look one level above and one level below as well. And especially in patients who are osteoporotic and have excessive spondylolisthesis and osteophytes, using this particular sequential fluoroscopy will be very helpful. As I said earlier, for transforaminal epidural injection, contrast is injected in AP view under continuous fluoroscopy via an extension tubing, unless you have digital subtraction. Save images. This is extremely important because you might have done the procedure absolutely fine, but if the patient has any problems or neurological conditions afterwards, or blames you for any neurological problems after the procedure, if you've saved the images and the images have been done, the procedure has been done correctly, then that saves you from any blame. So thank you all for listening to this. I hope you have enjoyed this. I will discuss the fluoroanatomy of cervical procedures and thoracic procedures in my next presentation. Thank you.